highlighted in that clip is, one, utilizing the resources that you do have to help you with your response. Not always on you to be the one doing everything, right? Especially when we're talking about ALS response, typically we're doing that kind of response in a situation where we have resources, we have personnel to at least help us do that response. So utilize the resources that are available to help. The second thing is, when you notice somebody doing something that's not right, go ahead and intervene. I'm blanking on his name, if you've ever watched Lost, but he was a lifeguard and was trying to do CPR but wasn't opening the airway. And when Jack tried to address the problem, he just kind of doubled down saying, oh, there's other things, let me go get that pen and do a crike, right? So he sent him off to kind of distract him and stuff so he can actually do the response. So if you're noticing response and you are the lead, you know somebody is doing something wrong, go ahead and correct them because you don't want them to continue to not respond appropriately and then ultimately the patient dies from that inadequate response. So correct folks when things are being done incorrectly. Okay. So let's do a couple check-on learnings from our last lecture, and then we'll talk about supraventricular tachycardias and ventricular tachyarrhythmias. So, but our first question is, which of the following conditions are typically necessary for the development of a reentrant tachycardia? So we talked about this in kind of the pathophys of the different types of tachyarrhythmias that we may experience. But the answer is bravo. So you've got to have a unidirectional block with a slow retrograde pathway conduction. We're going to talk a lot more about this today. So if you don't quite understand what that's asking, we will look into it a lot more today. So hopefully you'll understand why this is the answer to this question. Our next one is a 56-year-old female presents to the ED because of lightheadedness. An EKG rhythm strip is shown in the figure. What abnormality is present? Hearing Charlie, type 2, second degree AV block. Is that what you would agree with? Okay. I would agree with that as well. So why is this a Mobitz 2? So if you remember, first degree AV block is just a prolonged PR interval, consistent, right? No drop beats. And you have a P wave for every QRS and vice versa. A Mobitz, so a second degree AV block type 1, a Wenckebach, that PR interval is going to slowly march out before you get that drop beat, right? And then a second degree type 2 block is that PR interval is consistent, and then there's a drop beat. And then it goes back to consistent, and then a drop beat. So what you're seeing in this rhythm strip is this PR interval from this beat to this beat to this beat is consistent. You're not getting that marching out, right? And then all of a sudden you get a dropped QRS. And then it becomes consistent again for those beats. Now, third degree AV block, there is no communication whatsoever. So P waves are going to happen whenever they want. QRSs are going to happen whenever they want. So there is no consistency whatsoever. There's no predictability, nothing. So that is why this one is a second degree type 2 block. Does that make sense? All right. So we're going to talk about first about supraventricular tachyarrhythmias. So what this means is basically, so you have a ventricular tachyarrhythmia, but the origin comes from above the ventricles. So typically it's coming within the atria, right? Or at least the AV node. but it's coming from above the ventricles. So you're going to see some specific unique patterns with supraventricular tachyarrhythmias when we compare that to ventricular tachyarrhythmias. And there's a number of supraventricular tachyarrhythmias that you can see on this list. And we're going to talk about each one of these individually and learn how to recognize these different SVTs. When you go to kind of diagnose an SVT, one of the first steps to kind of help you differentiate between the different types is the R to R interval regular or is it irregular? Okay, we usually think of irregularly irregular rhythms as AFib, right? But it can also be a multifocal atrial tachycardia. So those are going to be your two rhythms that can cause an irregular rhythm when we talk about SVTs. And then unfortunately, then the breakdown goes to all the other SVTs are regular rhythms. So it takes a couple of diagnoses off your list if you notice that irregular rhythm. But it could still be any one of those other ones if it is a regular rhythm still. Patients, when they come in with SVT, they could be completely asymptomatic because one of the SVTs is sinus tach, right? Do you feel your heart beating fast when you're exercising? Well, not really, and hopefully not, right? Same goes with somebody who just happens to have sinus tach just developed for one reason or another. They may feel like their rate's a little fast, but the symptoms are pretty minimal. But the range can also be that they're having fatigue, they could be having dizziness, shortness of breath, chest discomfort. They may feel like they're going to pass out, or they may even pass out. It really kind of depends on not only the rhythm the patient's in, but also the condition of the patient. So a 20-year-old going into an abnormal rhythm is going to respond differently to that rhythm compared to an 80-year-old who has advanced cardiac disease, right? So the clinical scenario is going to be very different depending on your patient and their comorbidities and the rhythm that they're experiencing. The concern with somebody being in a SVT for a prolonged period of time is even though you still are getting a cardiac output of some sort, it can lead to secondary changes and patients can develop this tachycardia-related cardiomyopathy. So you can lead to a dysfunction of the heart. And there's lots of things that can lead and precipitate SVTs. It could be something as simple as a fever. It could be metabolic disease. It may be hormonal. It may be hypovolemia. There's lots and lots of things that can cause and precipitate this event to occur. So how do you diagnose this? Well, first of all, you got to catch the rhythm, right? Or the arrhythmia. So typically we're going to start off with a 12-lead EKG and see if in that 10-second snippet of time that we are given to take that EKG, let's see if we can capture that arrhythmia and diagnose it. The diagnostic yield, unless they are symptomatic at the time that you're doing the EKG, is pretty low, right? So there are the other prolonged monitoring tests that we can do. So we can do a Holter monitor, but it's only good for 24, 48 hours. We can do the Zio patch, which can give us at least 2 weeks of data. There are some instances where you can do it up to 30 days if needed, but you can understand somebody who's coming and going into this rhythm, it can be very difficult to capture it without having that continuous long, prolonged cardiac monitoring, right? We don't want to have these patients admitted to the hospital for 30 days just trying to capture an abnormal rhythm, right? So let's use our resources that we do have available to diagnose this. Now, the definitive way to diagnose this is going to be an electrophysiologic study, so an EP study, where we basically go in with wires and we interrogate the conduction system to see if there are any abnormal foci that are triggering and causing these arrhythmias. We don't do this on everybody who's getting this workup because it is an invasive test, right? There's high risks associated with doing this test. Not only with the passing of the catheters, but also with just messing around with the conduction system. We can elicit arrhythmias that could be life-threatening simply by doing the test and interrogating the system. Now, when you approach somebody with a tachyarrhythmia, one of the first questions you're going to see when we talk about treatment tomorrow is this person hemodynamically stable, or are they hemodynamically unstable? And basically, you can have it where a patient has one of these abnormal rhythms, one of these abnormal tachyarrhythmias, but they still at least have a normal blood pressure. They're maintaining normally despite that rhythm being so fast. But in other clinical scenarios, you can have it where that tachyarrhythmia does not permit an adequate cardiac output to really have much, if any, blood flow. So you may start to see signs of shock, basically, right? So blood pressure, systolic less than 90, changes in mental status because you're not perfusing the brain properly. They may have ischemic chest pain, which is going to be, of course, that squeezing, tightness, something sitting on my chest kind of feeling associated with this because you're not meeting the coronary artery supply and demand that's necessary. Now, with somebody who is unstable, do not confuse this with somebody who is in cardiac arrest. Because in cardiac arrest, there is no pulse. Somebody who is hemodynamically unstable can still have a pulse, and you're going to manage and you're going to treat that patient differently than if it's a true cardiac arrest patient. Now, you gotta be careful because it may, if you don't do anything to address the rhythm, you don't do anything to address the hemodynamic instability, it may go on and progress to cardiac arrest. So just at that moment, it's not cardiac arrest, but they could lose a pulse at any moment with this rhythm, or with these rhythms. But the big thing to take away when you are trying to manage one of these patients is, let's look for causes, reversible causes especially, that trigger this abnormal rhythm to develop. And when we talk about ALS tomorrow, it will list out what are your H's and T's. And fortunately, the algorithm actually has them listed out. So you can remember and look to see if your patient fits into one of these specific things that can be reversed and lead to a successful response. So let's first start talking about our SVTs with doing sinus tach, which is the most common tachyarrhythmia that you're going to encounter in your patients. So sinus, meaning it's in the sinus rhythm, right? Tachycardia just meaning fast, it's greater than 100 beats per minute. There's so many different things that can trigger this, and you got to be able to differentiate what exactly is it. Is it this patient's having an anxiety attack? Of course, now it's a chicken and an egg kind of discussion. Is it they have this rhythm because of their anxiety, or do they have anxiety because of this rhythm? They're feeling their heart beating, so they're getting anxious, and that's speeding up the heart rate, right? So there is some finesse to diagnosing this. Exercise. All of our heart rates go up with exercise, right? Because of that cardiac demand requires a higher cardiac output, the body adjusts and increases the heart rate to meet that. Anemia, hypotension, hypoxemia, fever, lots and lots of things can cause this. But one of the key things is rarely does your heart beat ever get above 180 in a true sinus tachycardia. Compare that to some of the other tachyarrhythmias that we're going to talk about. But one of the things you're going to see with a true sinus tach is you're going to see that P wave in the QRS in spite of that fast rate. And again, this is something that you're going to compare to with all the other tachyarrhythmias that we're going to talk about today. Now, there are these reentrant tachycardias, which there's two main groups to this. There's a atrioventricular nodal, let's see, where's my cursor? There. Nodal reentrant tachycardia, and then there's just atrioventricular reentrant tachycardia. That N for nodal is important. It differentiates the two because it's telling you where is this little short circuit occurring. Is it at the AV node, or is it outside of the AV node that short circuit is present? Because the treatment is going to be different. The definitive treatment is going to be different depending on where that is occurring. So why does the AV node have a short circuit? And the answer to this is the redundancy that we have to our conduction pathway kind of leads up to this happen, okay? So in a normal cardiac beat, you get that action potential generated from the SA node, right? And remember, there's those three nodal pathways, internodal pathways that go from the AV node to the SA node. And that's that redundancy system that's there. That action potential is going to work its way down those internodal pathways into the AV node. Well, one of those pathways is going to be, is going to have a faster conduction than the other two. So what ends up happening is that signal comes down in this regard, the beta pathway, and it's going to go through the AV node and then get conducted down into the His-Purkinje system. Now the other signal is going to use one of the other pathways, and this is going to take a little more time to get through it. It's just going to kind of bounce around or whatever, slow down. But then it's going to reach a point where this cell right here has already depolarized and hasn't had the opportunity to repolarize yet. So that conduction of that signal is going to terminate. It's going to stop right there. Now, if for whatever reason the other pathway doesn't conduct, let's say you have an MI, and that other pathway doesn't conduct that signal down, then that signal will then drive that cardiac beat. So that's why it's important to have this redundancy there. But let's add a little extra confusion to this. And let's say instead of the SA node triggering this action potential, let's say we have a premature atrial beat, say like AFib. That triggers, you have a different foci that's triggering that action potential generation. That action potential is going to get conducted down the slow pathway. And because that fast pathway is going to take a little longer for it to get around, what ends up happening is this action potential is going to get conducted down through the AV node, and then it's going to go down the His-Purkinje system. But the problem is this fork in the road that it encounters, this area has not depolarized yet because it hasn't gotten that action potential. So what ends up happening is it works its way up and then gets out of the conduction system and then kind of does that myocyte to myocyte conduction to re-trigger that pathway. And now you have this short circuit that does not allow the SA node to drive that rhythm. So you just have this uncontrolled, unregulated circuit, short circuit, causing this little spiral thing going around. So one thing I forgot to mention was, even though this pathway is slow to depolarize and conduct, it is fast to repolarize. So it is ready to conduct an action potential a lot faster than the pathway that tends to conduct fast. The fast conduction pathway has a slow repolarization phase. So it's not ready to depolarize when that signal gets to it, but it's repolarized and ready when you get that loop back around. So does that make sense? What's going on there in the nodal pathway? Well, that can lead to the AVNRT. It can lead to heart rates in excess of 150 beats per minute. And this is the most common SVT outside of sinus tach. This is the most common SVT that you're going to have in young patients. This is going to be your active duty folks. And I have had in my practice at least 3 to 4 different cases of SVT in sub 30-year-olds in my time practicing medicine. It seems like it's always when I'm deployed or in an austere environment where I don't have a lot of resources to help me manage these patients. What you can find with these patients who have this is a supraventricular rhythm, we said, so that means it's something above the ventricles. You're not really going to see a P wave, a normal P wave, like you would with a sinus tach, but the P waves, because of that retrograde conduction, may be after that QRS and inverted, which you see in this EKG example here. So you can see lead 2, of course, is our best lead for looking at P waves, right? You can see this little downward deflection after the QRS. And you may be asking yourself, well, is that just an S wave? Or is that an inverted, delayed P wave? And the way that this is answered is once we get them out of that rhythm, we then can look and see, hey, this doesn't have that little downward deflection. So it's not an S wave, it's actually that P wave just inverted and delayed to the QRS. But it's also not necessarily, when we talk about management tomorrow, it's not necessarily critical that you identify appropriately that that is a inverted delayed P wave. Okay. So here's an example of somebody with an AVNRT rhythm. So you're seeing, like we talked about, that inverted delayed P wave present there. We have, of course, a fast rhythm. When we count out, it's regular, but when we count out, let's say, what was that, 300, about 150, just over 150 beats per minute present. So that would be consistent with a tachyarrhythmia. Because I don't see those P waves prior to QRS as unlikely to be a sinus tach. But the QRS complex also is narrow. It's not wide or anything like that. So that is in a situation where that reentry circuit, that short circuit, is at the level of the AV node. But what happens if we have a reentry circuit, a short circuit of, say, like scar tissue or something, that's triggering that action potential to go from the ventricle and loop back around and into the atria? And that's what happens with AVRT, atrioventricular reentry tachycardia. So no N, doesn't involve necessarily the AV node. The reentry circuit doesn't involve the AV node. But what happens is you get that tissue called the bundle of Kent, that signal, that action potential from that previous beat should terminate in the ventricle. But because of that accessory pathway, it can then gain access to the atria and then re-excite, re-depolarize the cardiac tissue inappropriately. And the SA node does not drive this rhythm. Now, when this happens, there's a couple of ways that this can happen, and you're going to have a very different looking EKG waveform depending on which way this short circuit is going. Okay. And it also is going to depend on if you're in a normal pace rhythm versus it being in a tachy rhythm. So in a normal rhythm, what ends up happening, so the SA node is driving this, you're going to have that cardiac beat come down the AV node like it should, and you're going to have that brief pause that you normally see with that PR interval, right? You're going to have that brief pause before it then conducts down the His-Purkinje system. But you have that short circuit with that bundle of Kent, that scar tissue, and it also will conduct that action potential down through it, but it's going to do it in a way where there isn't a pause like there is in the AV node. So what ends up happening is you get that pre-excitation of the ventricular tissue, which is going to give you that delta wave that you see typical for this type of patient. Now, let's trigger a tachyarrhythmia, say from like an atrial fibrillation beat, atrial flutter, something like that. Let's trigger a tachyarrhythmia where now what happens, instead of that downward direction of the action potential from the SA node, let's say that it conducts down the His-Purkinje system, loops around the ventricular tissue, and then gains access to that repolarized accessory pathway, so it can conduct that beat from the ventricle back into the atria. It can then loop around and then conduct down the His-Purkinje system again. But this is going to do it in an unregulated fashion. So it's going to conduct as fast as it can. It's going to cause a rhythm based on how fast that conduction can occur. There is no like parasympathetic or sympathetic regulation of this beat, which is why you'll see these excessive tachy rhythms. The EKG findings, what's going to help you kind of differentiate this version of this circuit, is because you're using the His-Purkinje system in the correct direction, you're going to have a narrowed QRS. So it's going to look like a normal-ish QRS. It's not going to be wide. And this is called an orthodromic AVRT, which is the most common that you're going to see in your patients. But let's say that you have the conduction actually occurring down the accessory pathway, and it loops up around going in the backwards, the retrograde direction of the conduction system. And now you're working your way up. You work your way up through the AV node into the atria, and then it comes back down the accessory pathway again. So now you kind of have this you have this clockwise kind of rhythm to it. And again, this isn't going to be regulated by the SA node. The SA node is not driving this. But because we are using the His-Purkinje system in the wrong way, it's going to cause a delay in ventricular depolarization, and you're going to get a wide complex to your feelers. This might look like a ventricular tachycardia. So, but it actually is just this antidromic AVRT, where you have that short circuit occurring down the accessory pathway, looping up in the wrong direction of the conduction pathway, back around, and then regaining access through the accessory pathway. So, and that's going to lead to kind of a different appearance of what you're going to encounter with your patients. So this is going to be on the left-hand side. This is somebody who has that antidromic kind of pathway, where you get that wide complex QRS, and then it conducts down in that fashion, going in the wrong direction. But now let's put them in a sinus rhythm, and now you're seeing those delta waves occurring, but you still, the QRSs are still kind of narrow in appearance, right? You just, that PR interval is much smaller than what it should be. And that's, you slow the heart rate down in order to see that. Now, WPW or Wolff-Parkinson-White, you may be thinking AVRT sounds like Wolff-Parkinson-White. And the answer is WPW is a form of AVRT. There's a couple of others that fall under that, but WPW is the classic version of AVRT that we think about. You get the delta waves, right, because you have that accessory pathway being present, which leads to that PR interval being shortened. It's less than the 0.12 seconds. But the reason that we get concerned about WPW is it can then lead to a tachyarrhythmia that's not compatible with an adequate cardiac output. Here's just a couple of versions of WPW. So this is what we call type A pattern. And I'm not going to necessarily try to have you identify a type A versus a type B, so don't worry about that. But this is just going to give you a couple of different views of EKGs that are consistent with WPW. So you can see we are in a sinus rhythm. So I'm seeing P waves before my QRSs. We are not in a tachy rhythm, right? This is a normal rhythm, so this is a sinus rhythm. But you do see that shortened PR interval because you have those delta waves present, right? So this tells you that this is at least a form of AVRT. But when you actually look in more detail, this is that accessory pathway is on the left side of the heart. And it kind of mimics a right ventricular hypertrophy where you're going to have those tall waves in V1 through V3. And then you can see that R wave progression actually gets lower when you get to V6. It should be normal that R wave should be greatest in V6 and smallest in V1, right? So you kind of see that reverse of that R wave progression. This is a WPW type B pattern where instead of that accessory pathway being on the left, now it's on the right side, and now it's going to mimic a left ventricular hypertrophy, where you're going to have a tall R and inverted T in the inferior leads. So tall R, inverted. Sorry, tall R, inverted, tall R, inverted, tall R, inverted, right? So it's going to mimic a left ventricular hypertrophy, but when you look at the PR interval, it's shortened. And it's kind of hard to tell in this example, but you see it kind of comes up, and then it kind of stops, and then finishes off the upward deflection of the QRS there. So that is your delta wave present, kind of being buried into that tall R wave. Now, let's speed up the rhythm. Now we are in a tachy arrhythmia. This is what you're going to see. So this is orthodromic. So we're saying we're using, so the action potential is going up through the accessory pathway, gaining access to the atria, and then going down the AV node His-Purkinje system. And you can tell this because, one, you got your fast rhythm, right? But you have that narrowed QRS complex present. This may look like SVT, so guess what? We're going to treat it like SVT too. So you don't have to know that this is definitively orthodromic AVRT in order to manage it, okay? You're going to treat this like SVT. We'll talk about this again tomorrow with our ALS lecture. Now look at antidromic AVRT. So now we're going in a clockwise fashion where we're going down the accessory pathway, up in the opposite retrograde fashion or direction, through the Purkinje system, then into the His bundles of His, and then into the AV node to gain access to the atria, and then back down to that accessory pathway. And you can kind of tell that this is going on because look at how wide that QRS complex is, right? It looks different, it looks wide, especially when you're getting into these, the V1, V3, like those are very wide, complex QRSs. This looks like VTAC, well guess what, we're gonna treat it like VTAC as well. So again, you don't have to be able to definitively know that this is WPW just in an antidromic fashion in order to manage and respond to this tachyrhythm. And when we look at the treatment for this, you'll see that we typically do not use anything that's going to block the AV node because it actually can worsen this condition. So we're not going to do adenosine for this. We're not going to do beta blockers. We're not going to do calcium channel blockers. And we're not going to do digoxin in order to treat this. Again, we'll talk more about this, but ultimately what ends up happening if you have an orthodromic tachyarrhythmia, you're going to treat this like an SVT. Unfortunately, the majority of cases, this is what you're going to see. If it is antidromic, you're going to treat it like DTAC. And if they are unstable, well, we're just going to shock them. If they are stable, then we're going to do an antiarrhythmic like profenamide in order to try to get this into a normal rhythm again. Now you may be asking, well, let's look and see the difference of pre-treatment with an ablation where we still have that accessory pathway, and then let's get rid of that accessory pathway by ablating it. What is the difference going to look like in my EKG pattern? So here you have, it's kind of hard to see it on the actual lead 2, but when you look at lead 1, you can see you have your delta waves present. I'm not sure why this thing is coming into view. But you're going to see your delta waves there. So that tells you that you have conduction going down an accessory pathway. Well, now I do my electrophysiologic study, my EP study, and I find where that accessory pathway is, and then I burn it. I get rid of it. So now the action potential cannot conduct down that accessory pathway, and now you can see that that delta wave goes away, and now I have a normal looking QRS complex with a normal PR interval. Okay. So that's what it's going to look like pre and post ablation for this patient. Okay, so those were AVRTs, AVNRTs. Any questions about those reentry tachycardias? Okay. So let's move on to some of the other SVTs that we may see. So the first one we're going to talk about is a focal atrial tachycardia. Focal meaning like single, right? This is a single foci in the atria is driving this rhythm. It's not the SA node, it's something else. And when you look at the rhythm on the EKG strip, what you'll see is this P wave looks the same from beat to beat, but that doesn't look like a normal lead 2 P wave, right? It's downward deflected. It's not upward deflected like we normally see when the SA node is driving this rhythm. The other thing I notice is that R to R interval, excuse me, the R to R interval is consistent from beat to beat to beat to beat. It doesn't change, okay? So this is a regular rhythm with a single atrial foci driving it, focal atrial tachycardia. And there's lots of things that can cause this to develop. So it could be that they have an enhanced automaticity that's triggering this. It could be a triggered event. It could be digoxin toxicity. Could be excessive stimulants like cocaine or caffeine that causes stress can even cause this. So lots of things can cause this condition. Now the problem with this condition is, yeah, you may be completely asymptomatic, but if you have this abnormal foci driving this rhythm that's consistent, what is regulating that foci and how quickly it's going to work? So it could lead to a fast ventricular rate, and then that can lead to an tachyarrhythmia. That could lead to decreased cardiac output, which then can lead to, of course, morbidity and mortality. So typically what we do when we encounter somebody with a focal atrial attack and they are symptomatic is let's manage them with slowing down the AV node with beta blockers or calcium channel blockers. And then we can also use the antiarrhythmics to help us keep that rate low. And then we could do an EP study to find out where that abnormal foci is, and let's get rid of it. Okay, especially in patients who are unstable or have severe symptoms related to this, or you have them on a beta blocker or calcium channel blocker or antiarrhythmic, and you cannot control the rhythm, then you may have to go in that extra step, that more invasive procedure, and get rid of that abnormal foci. Now, let's compare to the multifocal atrial attack. Let me try to get rid of that. There, hopefully that works. Let's look at multifocal atrial attack. Now compare this to what we just talked about with focal atrial attack, where you have that single foci that has that consistent P wave looking thing, right? But now, instead of having just one foci driving this rhythm, let's say we have at least 3 different foci driving this rhythm. So now I have a foci over here in the atria, and this foci over here, and then I have this one over here. All of them are generating action potentials, and all of them are sending that action potential down to get conducted. And then one beat, this one gets it, the next one, this one does, and the next one, this one does. And when you look at this, you'll see, look at all the morphologies of the P waves. Does that one look like that one? Not really. Does that one look like any of those other 2? No, not really. Here's another one. Does that one look similar? Nope. And then here's another one. And then you start getting into a point where, okay, this one kind of looks like this one. This one kind of looks like this one. So you can see, yes, you have multiple foci doing it, but it's not like an atrial fib where you have hundreds of different foci triggering this event, right? There is some consistency there. But unfortunately, we can't regulate, regulate that rhythm from all of those different foci. So what ends up happening is you're going to have an irregular rhythm associated with this. So this R to R interval is not the same as this R to R, which is not the same to this R to R, and so on and so forth. So you'll see that irregularly irregular pattern with multifocal atrial attack. And the kinds of things that can trigger this, think of like your pulmonary diseases causing these or this to develop. That brings us to about 10:50, so let's go ahead and take 10 minutes, and then we'll finish up. We finished talking about multifocal atrial attack, so we're still talking about supraventricular tachyarrhythmias. We still haven't finished that, unfortunately, but if you recall from the very beginning, the 2 rhythms that typically, the 2 SVTs that typically give you a irregularly irregular rhythm was multifocal atrial attack, and then the other one is atrial fib. So let's talk about AFib, which probably something you can recognize that there isn't like a definitive P wave present. There's just all these little waves there. And it's because you have so many different foci in the atria that's causing the atria to just kind of quiver. There is no organized squeeze with AFib because you have so many different foci going off trying to elicit a cardiac response that they kind of overwhelm each other and they don't really conduct down the pathway necessarily. There may be a couple here and there that will conduct down to give you that QRS response, but the vast majority of these foci are not going to cause a QRS depolarizing event. There's lots of different things that can cause this, but in the next slide we'll kind of show that, but there's the clinical presentation for this could be completely asymptomatic. They have no idea it's there. The only reason we know is because we did an EKG that showed this AFib rhythm present. You may be able to feel it on the pulse, just this irregular rhythm, but that may be the only way we know that they have this rhythm. But let's say that this atrial fibrillation leads to a fast ventricular rate. Now I have a tachyarrhythmia that is being generated above the ventricles. That's why it is classified as an SVT. And that could lead to symptoms. Because now that ventricular rate response is not controlled necessarily. It's just at the whims of that atrial fibrillation wave. And you can get rhythms in excess of 150 beats per minute, which then can lead to poor cardiac output, poor diastolic filling time, and all that kind of stuff, which then can lead to symptoms like heart failure or even presyncopal episodes from that. Here's the list of things that can cause it. Goodness gracious, I don't know why. Let me switch to let me swap views. That better? At least on my screen, it's kind of distorting. There's like some words coming up in the background. It's kind of distorting it for some reason. But okay, so the acronym PIRATES can help you kind of identify some causes of AFib. Okay, so P being pulmonary causes. You have a whole class dedicated to this. Just know cardio and pulmonary system play hand in hand in a lot of ways, right? Rheumatic heart disease, we talked about last block, right? Mitral regurgitation, alcohol. Remember, alcohol, especially in excessive quantities, is cardiotoxic. Anemia, thyrotoxicosis, toxins, electrolyte abnormalities, sepsis, sick sinus syndrome, all those things can precipitate and cause AFib to develop in your patients. When you look at the EKG, what you'll see is if you measure the atrial rate, it can vary from 350 to 650 beats per minute. Can you imagine your heart rate responding, your ventricular rate responding to every one of those P waves? That'd be crazy. You're like a hummingbird at that point, right? But the ventricular rate is going to be much slower than those P waves or that atrial rate is. So not all of those atrial waves is getting conducted down the AV node and into the Purkinje system. So the ventricular rate could be normal, 60, 70 beats per minute, just in a irregular fashion, or it could speed up to rates in excess of 150 beats per minute. So it's going to vary. Now, a couple of definitions that can be applied to AFib is if this person has AFib that develops and it spontaneously terminates within 7 days, which seems excessive, this is considered paroxysmal. So you get a week of being in AFib and letting itself terminate, and now you've got paroxysmal AFib. If it lasts longer than 7 days, then it's considered persistent or chronic, right? And then it's permanent if it's all the time, it's recurrent if you've had at least 2 or more episodes of this. One of the key things when we look at the treatment for AFib is what about the formation of blood clots? If you have AFib you're having stasis of blood flow, right? So you're gonna have blood flow that's just gonna sit there and not really move. Blood that's not moving clots, unless you're on an anticoagulant, right? So what's the concern? What's the risk of having that static blood flow and that clot formation is what happens if that clot now gains access to blood that is flowing and now it gets sent downstream. We talked about it in neuro with strokes, right? We talked about it in our class regarding thrombotic arterial disease, right? The mesenteric thrombosis that could go to an extremity and cause complete blood flow loss, arterial blood flow loss to an extremity. So there's so many different problems that can be associated with that. So you have to know whether or not to anticoagulate a patient. And one of the things that can help you, one of the scoring tools you can use to help you differentiate those who need anticoagulation versus those who don't is using the CHADS-VASc score. Okay. Men typically will get anticoagulated if they get a score of 1 or higher. And women, it's a little more forgiveness, but you get 2 right there. Score of 2 or more is typically recommended for anticoagulation. So, now the other thing to talk about from a treatment standpoint with AFib is the 2 different approaches that you deal with the rhythm. Do you rate control it, meaning that you just keep that heart rate so it doesn't get into that tachyarrhythmia rate? Or do I want to put them back in a normal rhythm? So is this a rhythm control? And your cardiologist will help you decide which approach to take. Because most folks, if they just get that rate control, are fine. They just take their daily beta blocker or calcium channel blocker, and their rate stays out of that tachyarrhythmia, and they're completely asymptomatic, have no idea that they have AFib. Now, if you feel their pulse, you're still going to feel that irregular rhythm. It's just not going to be a fast rhythm. If I do a rhythm control strategy, now I'm trying to get them back into that normal rhythm, and I'm going to do things like shock them. So I'm going to do a cardioversion, or I'm going to put them on an antiarrhythmic to try to get them back into that normal rhythm. So things like amiodarone is a good option for a rate control fashion. So just know when you deal with AFib, what is your treatment approach? Is it rate control or is it rhythm control? The next tachyarrhythmia we're going to talk about is A-flutter, atrial flutter. So of course we all know the sawtooth pattern, right? That's present. But when you look at the atrial rate, the sawtooth pattern typically is in a rate of 180 to 350 beats per minute. Again, not every one of those waves is going to conduct down into the ventricle. So you're not going to have a QRS for every atrial wave, which is great because, again, imagine your heart rate being in excess of 300 beats per minute. Now, one of the things that's kind of interesting is you get that sawtooth pattern. So if I look at the next slide, that sawtooth pattern can have two different appearances to it, depending on, is this going around counterclockwise or clockwise? And you can see in the bottom left here what those flutter waves are going to look like if they're going in those two different directions. I'm not going to ask you on the test to identify which way is this flutter wave going based on the EKG. Just know that the flutter waves can have two different appearances to them. And it's because of the direction that they go. Now, going back a slide, what can cause somebody to be at risk of developing a flutter? So we've got pericardial diseases, but we also have, if I put left atrial or right atrial enlargement. I get that stretch of the atria. I am stretching the conduction pathway in a fashion that is not normal, and that is going to lead to that stress being placed on the conduction pathway, leading to these abnormal foci triggering this rhythm to be present. Thyroid disease. Have thyroid disease on your differential for really any cardiac disease, because as you can see, there's a lot of impact on the heart and the cardiovascular system from thyroid disease. But hypothyroidism can also put you at risk for this. And then when we look at the EKG criteria, so atrial rate is going to be 220 to 430 beats per minute. And then ventricular rate is obviously much slower than that. Okay. So how are we going to treat it? Well, first of all, I'm going to try to prevent them from having a tachyarrhythmia leading to poor cardiac output. So I got to do some kind of rate control with using like beta blockers or calcium channel blockers to keep that rate low. But the concern is that these folks could develop this rhythm again. They're at high risk of it developing again. So we need to do some type of procedure to prevent this rhythm from developing again. So they typically will go through that cardiac ablation to get rid of that abnormal foci, or at least that pathway, so that you don't have that developing, or this rhythm developing from it. And we've talked about ablation, and we talked about this is typically something that you do with an electrophysiologic study. You thread those catheters in, and then you test the conduction pathway. But the ablation part to it is can be done in a couple of ways. We can either do like a radio frequency ablation, so I kind of focus radio frequency into a targeted area that then kind of cauterizes or gets rid of that tissue. I can use cold, so cryoablation. Also, I can also use heat ablation too. So I can use things that kind of damage or destroy that cell locally. And this is important because typically for SVTs, we consider this a first-line treatment for AVNRT or AVRT. So we have those accessory circuits going on, right? As well as aflutter. But we have to be careful when we do this, because if we're a little over-aggressive in our burning of the tissue, I could punch a hole through the ventricular septum or the atrial septum, and then now you have things like cardiac tamponade, or I damage the conduction pathway, like the inherent normal conduction pathway, excessively, and now I'm developing AV blocks and those types of things. So there are complications associated with the radio frequency or with the ablation part to it. And we would prefer, when we have to approach this kind of treatment, we would prefer to do that radio frequency ablation or using that ablation because even though there are risks associated with it, the risks are a lot less than if I do this surgical approach, which you see in this image. This is called a maze procedure. And all of those dotted lines are where I am going to cut through. Then I reattach them. But what I'm doing is, if I cut here, if I cut there, if I have an atrial wave or some abnormal rhythm or an abnormal foci trigger an action potential in here, it's going to be restricted to this area. And it's not going to then elicit a ventricular response, because it's just going to kind of die right in that area. Once it gets to that scar tissue area, it's going to die. But you can imagine this is an open heart procedure. We're cutting, we're suturing. What's the chances of bleeding and perforation and all that kind of stuff? You understand, there's a huge risk associated with this surgical procedure, that the risks of the ablation procedure are far less than the risk of doing this surgical procedure. Now, a couple exceptions before we move on to ventricular arrhythmias. If you have a narrow and an irregular rhythm with a stable patient, you usually choose to rate control prior to cardioversion. So we're not necessarily jumping into shocking the heart. We try to do that rate control first. If they have AFib or multifocal atrial tach and they are stable, we will do like beta blockers and calcium channel blockers as kind of our first line. If you're going to choose the calcium channel blocker, diltiazem is first line, with verapamil is kind of second line. If they are unstable, then we're shocking the heart, trying to get them into a normal rhythm. So, and we'll talk about that in our ALS lecture tomorrow. Okay, so that is all the SVTs. Fortunately, there's only a few of ventricular arrhythmias that we have to talk about. So we said an SVT, a supraventricular tachyarrhythmia, is something where that foci is being triggered above the ventricle. Well, a ventricular arrhythmia, that foci that's triggering that abnormal rhythm is now in the ventricle. Okay? So that foci is in the ventricle. Well, how is that going to change how we see that rhythm if that foci is in the ventricle as opposed to in the atria? Well, first of all, you're going to have rate ranges that are going to be, of course, this is a tachyrhythm, right? So it's going to be anywhere from 150 to 250 beats per minute. P waves may be disassociated, or you're not going to have them at all. We are not using the His-Purkinje system in the correct fashion necessarily, so it tends to be a wide complex QRS. So the QRSs tend to be wide. And the things that can cause somebody to develop into VTAC in particular, so we're talking about VTAC, is something like a heart attack, myocardial irritability because of like an inflammatory process with myocarditis. It could be drugs, which can be either both illicit drugs or prescribed medications in excess or out of parameters, right? Electrolyte disturbances, which we'll talk about on Friday. And then, of course, structural heart disease, where you have changes that occur in the cardiac muscle and tissue itself. And the way that somebody is going to present with VTAC is they can be asymptomatic from it, have no idea what's going on, or they can be actually in full cardiac arrest and have no pulse. So not a great clinical assessment on this because they can present in such a wide range of their condition. Here's an example of what we call a monomorphic ventricular tachyarrhythmia. So this QRS complex looks very similar to this one, in not only in shape but also in amplitude too, so monomorphic. You can have a polymorphic VTAC that you see in this pattern where this QRS does not look like this one, which does not look like this one, and the amplitudes are different too. So there's a change from beat to beat to beat, and this would give you a polymorphic rhythm or a polymorphic appearance to it because there is no consistency in what you see. There's several things that can cause this VTAC to develop as well. So you can have that irritable ventricular focus. You can have consecutive PVCs, like complexes, so that premature ventricular contraction. Or you can have that R on T phenomenon where you have that brief period of time that is called the vulnerable period where a abnormal foci will then trigger or hit that area at the wrong moment, and then it can precipitate this rhythm. And we'll talk about this tomorrow when we start talking about shocking the heart and why this concept is important in the situation of us putting energy through the defibrillation. So here's an example of the EKG with VTach. If you're looking at it, this QRS looks similar to this QRS, this one, the similar amplitude, so you know that this is a monomorphic VTach. Now, we don't know based on this EKG, do they have a pulse or not? So you're going to have to feel for a pulse. But do you see P waves? The answer is not really, no, right? Is it a fast rhythm, slow rhythm, normal rhythm? Obviously a very fast one, right? So you can see this is what a classic monomorphic VTach will look like. Here's a couple of, so this is, I'm not going to necessarily test you on this, but these are some other terms that you may hear. So you may have what's called a fusion beat, which, does this look like a normal QRS complex? No, not really. What's happening is you have that VTach rhythm that's hitting that SA node, trying to drive that rhythm, and it's going to make it look somewhat like normal. It's definitely going to look different than the VTach rhythm, but it's not normal, okay? So this is a fusion beat where you get that VTach and that normal beat fusing together. Now, you can then have a captured beat, which is when now, despite having that VTach present, now the SA node, or the atria, ends up regaining control, even if it's just for that beat, and it looks like a more normal P wave, QRS, T wave. So here's your P wave, you got a Q wave, but you have your QRS, and you have your T there. And you can see a couple of examples of that on this rhythm strip down here. Here's your fusion beat. It looks different than your VTach waves. But then you get like the normal-ish looking ones here, which is your captured beat. Another concept that we have to talk about is QT prolongation. So normal QT is less than 440 milliseconds, or 2 large squares. It is considered prolonged if it's greater than 450 milliseconds. Folks who have this condition, the presentation or the clinical scenario could be they have no idea what's going on, they're just asymptomatic from it. It could be that they have syncope because that prolongation is so long, you're just not meeting that cardiac output appropriately, so they're having syncopal episodes, or they could be in cardiac arrest from this as well. So a wide range that somebody may present with QT prolongation. Now there's lots of different causes of this, so it could be a genetic mutation where the ion channels are mutated, so you have a longer dragged on repolarization phase. Or it could be that they have had like a heart attack or have some other kind of conduction block that's present that's triggering that QT to be prolonging. It could be there's some electrolyte abnormalities. And you can see that this tends to be low electrolytes, so hypocalcemia, hypokalemia, hypomagnesemia, where basically because you don't have a proper amount or proper concentration of those electrolytes, things just take longer to happen. And then of course, something that you may do is you may prescribe medications that can cause QT prolongation. And this is probably the most common cause of QT prolongation you're going to encounter in your clinical practice, which could be from poor prescribing techniques, but it could also be from inappropriate medication use on the patient level, i.e. overdosing on SSRIs and the suicide attempt. So what meds can cause this? it's probably good practice just to kind of go online and look at QT prolonging medications, but just kind of a rough idea of this is your anti-A, anti-B, anti-C, anti-D, anti-E medications. So your anti-arrhythmics, some of them, so class 1As, 1Cs can cause it. Your antibiotics, particularly like your macrolides, fluoroquinolones, and your antifungals. Anti-C, which is antipsychotics, so Haldol. Antidepressants, so TCAs can cause this, but SSRIs can also cause QT prolongation. And then even your antiemetics can cause it. So ondansetron is the common one. Even metoclopramide or Reglan at higher doses can cause QT prolongation. So be careful with the use of that. If you are in question or whether or not this person might be at high risk of developing this, but you want to give them ondansetron to treat their nausea and their vomiting, well, just get an EKG and just check what their QT interval is before you prescribe it. Okay. But one thing you have to be careful of is if I have a patient who's on one of these other medications that can cause a QT prolongation, what happens if I put them on another one that causes QT prolongation? You may get it, so they're like, yeah, 455 milliseconds is that QT interval, but now I put them on that next one, and now I'm at 500 milliseconds. Now I'm putting that patient at a much higher risk of developing a fatal arrhythmia, right? So be careful. Make sure you're doing that great medication reconciliation and think about QT prolonging when you prescribe meds that can cause that. You're going to see so many nausea, vomiting, diarrheas in your clinic that you're just going to be giving out ondansetron. You may even be tempted just to put it on the corner and just people come and get it whenever they want, right? But you've got to be careful. You've got to make sure you're doing the right medication, right patient, right time, right indication for it, and avoiding something like this from happening. Because what can happen is that QT prolonging can then precipitate into torsades de pointes, or twisting of the points. And this can lead to a fatal arrhythmia and lead to death. The way you treat it is, first of all, you're going to do magnesium to stabilize the cardiac membranes. This is not oral magnesium. Okay? What's a great oral magnesium? Milk of magnesia or magnesium citrate, what do those do? You poop your brains out, right? So, don't give them magnesium orally. You're going to give them IV magnesium in this situation. One, because it's better tolerated, it's faster infusion, faster effects, but hopefully then they're not on the toilet for the rest of the time after you save them. They may be wishing you hadn't saved them after that. So give them magnesium as a first line to stabilize the cardiac membranes to decrease the chances and risk of developing into a fatal arrhythmia. If they are unstable but have a pulse, so unstable meaning hemodynamically unstable, so decreased blood pressure with systolics less than 90, altered mental status, ischemic chest pain, those are the things that make you unstable. But if they still have a pulse, then you're going to do a synchronized cardioversion. So you're going to synchronize the shock that you're going to deliver to the patient. And we're going to talk more about this tomorrow. If they are unstable and they do not have a pulse, then you're going to defibrillate them. Okay? And we'll talk about the difference between synchronized cardioversion and defibrillation tomorrow. Here is a look of somebody who went into torsades. So we said QT prolongation is puts somebody at risk of developing torsades. Look at this QT prolongation. Does that look normal? The answer, of course, is no, it's not, right? So you had the setup for this patient to go into torsades, which is a polymorphic VTach appearance to it. Okay. So that's VTach. The last rhythm that we really need to talk about is, well, actually, second to the last rhythm that we need to talk about is VFib, ventricular fibrillation, similar to atrial fibrillation, other than instead of the fibrillation waves occurring in the atria, you now are having this fibrillation occurring in the ventricle. When we talked about atrial fibrillation, we talked about how there's not an organized response. There's no organized squeeze to circulate blood from the atria and into the ventricle. Well, now that you have that VFib, that ventricular fibrillation, kind of the same thing happens, just now you aren't having a pulse because you're not having a ventricular coordinated squeeze that occurs with it. So this is not a life-sustaining rhythm to be in. We're going to look at the EKG on the next slide, but things that can cause this are things like you have a massive heart attack that triggers it. You can have some acid-base disturbances with torsades. We'll talk about electrical shock in an inappropriate setting. But even hypothermia, severe hypothermia, can lead to this rhythm. And the presentation of it is going to be, they don't have a pulse, and the heart is not functioning and can lead to death and not responding to treatments. Here's an example of VFib, looking at the heart rate, if you want to call it that, is on the EKG. It should be about 300 to 600 beats per minute. But again, these are going to be pulseless, so these electrical waves are not going to lead to a functional response from the myocardium. And here's just an example of somebody who has idiopathic ventricular fib that has some PVCs and stuff like that. So, the last rhythm that we need to talk about before we talk about treatment tomorrow is pulseless electrical activity. So this is a rhythm where when you look at the EKG, you look at the rhythm strip, it's somewhat organized, and you would think that this person should be alive. You would think that this rhythm should lead to a ventricular squeeze. So you should have some kind of cardiac output associated with this rhythm. But they are pulseless. So you have the electrical conduction occurring to have that organized response, but for some reason, there is no functional response at the myocardial level. So don't be falsely reassured if you are responding to a code and you get a rhythm change and it looks like this, and you're like, oh, this is normal, this is great. Slap hands, let's go on about our day. You gotta check the pulse to see, is that rhythm leading to an organized response and leading to a circulation of the blood. Now, if you have somebody with pulseless electrical activity, we're going to talk about how you manage this tomorrow. But you got to be looking for, well, why is it they have this? Let's look at our H's, let's look at our T's, and let's see why they may develop this rhythm. And this 2 up, 5 down, 2 heart, 2 lung, we'll look at tomorrow when we look at the specific causes of your H's and T's. That will make a little more sense, but I will give you that list on the test as far as what your H's and T's are. So, anyways, so we have now essentially finished all of the topics that you are required to know for the PANCE in the cardiovascular system. We're going to talk about how to manage these tomorrow with ALS, and we're going to talk on Friday about how we are things that can affect the EKG. But as far as like specific topics required to meet the PANTS blueprint. We have now finished all of that. So, do you have any questions before we break for the day?